invite Laura Adang, to come to us from CHOP and report about newborn screening responses and long-term monitoring. And I know she's a fantastic speaker, so I'm glad to have her.
Thank you very much. Can everyone hear me okay? I will try and honor this side of the room too, because I feel like you got a little neglected. So today I have the honor of presenting some really exciting work that was not done by me, but was actually done by most of the people in this room. And it really is the backbone of how we're going to help people with ALD is finding it before it's symptomatic. So in order to talk about these important journey that we've had with ALD, we first need to talk about the journey to the newborn screen. And this was decades of work and effort that I'm going to literally boil down to one slide. So please don't be offended. I realize it was a very long process, but we really need to spend most of our time talking on that now what. We're going to briefly touch on the pathophysiology of ALD because I am the first speaker after the introduction. I just want to make sure everyone in the room is caught up. We're going to briefly talk about the genetics because it's fairly unusual among a leukodystrophy. We're going to talk about the screening protocol we have at CHOP and how we're trying to integrate that around the country. And we're finally going to talk about the future, which is really the most important part of how we are going to help children. The backbone of a leukodystrophy center and being a physician that cares for children and adults affected by leukodystrophy is really a comprehensive clinical care system. It's caring for the child from top to bottom, every single organ system, mental health, emotional health, all of those things. Developing novel therapeutics. Now all three arms of ALD, we have up-and-coming therapies, which is thrilling and exciting, but how do I get it to families if I don't know they have the disease until they're very symptomatic? And so really the foundation of giving the best clinical care is preventative care, and the foundation of the most effective therapeutics is identifying the children before they're symptomatic, which is why it's amazing we now have a newborn screen. That's a game changer for any disease, but is particularly important for this disease, which can be hard to really know what's going on until it's much too late. And we think about 250 or more children are going to be identified in the United States each year through the newborn screen, which is a fabulous amount of children we can potentially save or at least drastically change their life course. The long road to newborn screening in one slide, it was decades of work, lots of hurdles, but they had a great test. They have a good treatment. It was added to the RUSP, which is the National Recommendation Panel. And then slowly, we're getting each state to approve it being added to the newborn screen platform. So identifying the children at risk, check. Having great interventions and therapies, check. But the big problem is how do we monitor? How do I know a child might be affected and catch them in the right way before they need an intervention? So very briefly, ALD pathophysiology. I know there are people that have devoted their life work to this. It's like 2 slides. We make very long-chain fatty acids, which are essential building blocks within the cell. Those very long-chain fatty acids need to be recycled and processed, and that happens both through the peroxisome and the mitochondria. And in order to get into the recycling center, what you need is a transporter, ABCD1. If you can efficiently transport in it, great. Your very long-chain fatty acid levels are very low, you're recycling. But if you have a change in how your cell is able to recycle these because you have a switch in how efficiently your body is recycling the very long-chain fatty acids, what happens is they start to build up. And through very complicated mechanisms, they cause one of 3 overlapping phenotypes, which Florian very nicely outlined. Our goal with the newborn screen is at birth to be able to measure elevated very long-chain fatty acids and intervene before we have any of the pathologies. So the genetics, again, very briefly, it's an unusual disorder in that it's X-linked. That means men and women are affected differently. If a mom is carrying one change in her ABCD1 gene, then for her children, she has one female carrier and one affected male, and then she has a 50-50 chance of not having any affected children. For men, it's completely different. if a father carries that gene, they have a 100% chance of their girls being carriers. And I put carriers in quotes because that's what it's in the literature, but we all know it's not actually carriers. Women are affected, they're just affected differently. But their sons have no risk. And then 5% of children we think are de novo. That means neither parent had the change, but it just spontaneously happened in them. That has really big implications for family planning. So what about on the gene level? So normally your DNA encodes the sequence that becomes your protein. It's the message. That's turned into mRNA, which is turned into protein. If you have a variant, which means a change in your signaling, what happens is that variant then goes from DNA to RNA, all into the protein change down at the bottom. And there are 3 general classes of variants. One is normal, right? That means you might not be spelled exactly the same way as everyone else, but that's okay. You're still able to make your transporter. And then at the bottom is known pathogenic. That's a little bit easier to deal with too. We know when you have that change, you have a type of the disease. In ALD, I can't tell you which form you're going to have, but I can say you're likely to be affected. What is the bane of all geneticists and neurogeneticists is these VUSs, or variants of unknown significance. Those haven't been described before in the literature, and so we don't know how it's going to affect a family. Part of the difference with VUSs is that our database of normal is almost entirely white Europeans. And so anyone of color from, Botswana, for example, they're not going to be picked up as normal because their ethnic spelling is just slightly different. It doesn't mean they have the disease, but it's one of the things we're grappling with now in the field. So now to the meat and potatoes of the talk is what we do after we identify a child as having ALD by the newborn screen. So again, from infancy, we can pick up that elevation in very long-chain fatty acids. And this is a really good test, actually. There were no false positives on the initial validation study, which means there was no one told that they had ALD who didn't have ALD or another disease. Also, most neonates are asymptomatic. The earliest cases of adrenal insufficiency published are 5 months, although I've heard hints that it might be even a little bit earlier than that. But that means, unlike some diseases on the newborn screen, we have a little bit of time to make sure we can meet the family and do things right. Other caveats is the newborn screen test is a screen test. It's not a diagnostic test, and so when you meet a child, you need to confirm that they actually have ALD and not something else. Each state has a different protocol, and so when someone is referred to your newborn screen clinic, state by state, you'll have a different quality of information. New York, in particular, they get very good quality of information, whereas in Pennsylvania, we're very careful about making sure that we're really diagnosing a child properly. You have to explore the family tree. We know that the genotype-phenotype correlation, which is how your one individual spelling change affects how you're physically manifesting the disease, is poor at best for ALD. So just because I'm identifying a child and the family tells me no one is affected, we really push carefully. We've diagnosed many a grandmother with primary progressive MS is actually having the female version of ALD. It's also possible that a child, a baby boy or a baby girl, was screened positive, but say they have a male cousin who is too old to get the newborn screen. So for the next 5-10 years, we need to make sure that even young children we're looking very carefully at and understanding what their individual risks are. The test is designed for boys. It's not designed for women or little girls that are screened. So typically, boys have very high levels. Normal is way down low, and the women are somewhere in the middle. And so there's about a 20% chance of testing a little girl for ALD and actually getting a negative, right? So even if she's a carrier, it's just because she's on the borderline. And every state and every clinical laboratory actually has a slightly different threshold for where they say a positive for very long-chain fatty acids is, so something to be aware of as well. We know that there are multiple disorders that result in a change in your very long chain fatty acids. So by the newborn screen, if your state screen is not actually doing the genetic test before they refer a child to you, what we need to make sure is that you're not actually calling something ALD, but it's a completely different disorder. Right? So there are peroxisomal disorders that can cause it. In New York, there was one case of Klinefelters, although I suspect they actually were a carrier. And then Cardi-Gutierrez, we know, has been caught by this as well. So anything that makes the peroxisome angry is going to make your very long chain fatty acids high. This is our general strategy here at CHOP. When we get a child with elevated very long chain fatty acids, the first thing we do is a genetic confirmation, right? If they have a known pathogenic mutation, that's relatively easy. I know what protocol I send them into. But if they have a VUS, or if they have no change that we've seen before, then we have to do a little bit more investigation just to make sure we're not missing another genetic disorder that's just made the peroxisome upset. We also have to be very careful, and this goes back to that comprehensive clinical care, that we're caring for the whole child. ALD is not just a disorder of the brain, but is also a disorder of the adrenal system. And so we have to have comprehensive screening and treatment protocols for both organs. This is our CHOP protocol. It changes, I'd say, about every 2 months, right? As we get more information, we have more meetings, I get more feedback from other providers about what they've seen and what they've experienced. But roughly, babies have to see me every 3 to 4 months for most of their life, right? And we haven't set our protocol for what happens after you're 18. I think that that's a big issue too. How long do you need MRIs for? We recently have switched our youngest date where we begin to get MRIs to 12 months based on kind of our national experience. It doesn't mean that this is perfect or right. This is not evidence-based. This is anecdote-based. We also use the beautiful guidelines that were recently published for adrenal function, and I believe you'll get to meet with Dr. Roizen tomorrow to talk about the CHOP approach to the endocrine dysfunction. But the big point about the newborn screen is that it is a work in progress. It has a future, and it will need to evolve. We need to better understand the genotype-phenotype correlation. Let's say there's one change where in all families, if you have that one specific change, you only have one form of the disease, then do you really need to put a child through every 6-month MRIs for their entire life? No, probably not, but I need to prove it completely before I would feel comfortable not doing that level of screening. I'm interested in finding out what the de novo incidence of this disease is. Right now, we think it's around 5%, but once we do the agnostic testing, meaning you're checking every single baby that's born, we may find that that number changes dramatically and is far higher than the 5% that we think. We're going to know how to better deal with variants of unknown significance. We'll be able to define new variants of unknown significance actually as normal or actually as pathogenic. And we've had several cases in Pennsylvania that we've been now able to categorize based on getting a good family history. And then this ideal screening protocol. I think it's really important that all of our groups are talking, and many of us are, but I want to make sure everyone across the nation is talking. As we have all these states rolling out programs, we need to make sure every single institution that sees children screened by the ALD newborn screen gets the exact same protocol regardless of where you live, right? We have a fairly similar protocol to, Boston Children's, hopefully, and Johns Hopkins, hopefully, but there are lots of places that I want to make sure if you screen positive Kansas, you get the exact same care as you get if you get screened positive in Boston. And really, the key to this, and underscoring what Florian was saying, is big data and natural history studies and being very open and collaborative within the community, because I don't know what the right screening protocol is. We do the very best we can, but there are risks to overscreening as well, right? I don't want to get an MRI every month, but can I wait a month? Can I wait an entire year? Those are the questions that we need to answer in the coming decade as we better understand this very new and different population of children affected by ALD. So in closing, hopefully I made up for some of the lost time. In closing, I want to thank ALDonnect. I think that bringing together a group and a community to understand ALD is a really key first step, and then we need to disseminate this information to centers all around the country so that everyone is getting the same care. I'd like to thank my collaborators in the newborn screen program. So I run the neurology side of our newborn screen program. Dr. John runs the metabolism program, and Jeff Roizen was instrumental as well as setting up our endocrine protocol. And then our CHOP Center of Excellence for Leukodystrophy is led by Dr. Vandiver that I see over there. Hello. And I would love to have a discussion about how other protocols around the country are different, how we can make sure that all centers are standardized around the newborn screen, and any other experiences people want to share. So thank you for your attention.
That was great, Laura. Maybe just to pick up on that question you raised. So how is it that based on the experience of centers like CHOP that are early in this process, and can we roll out protocols or guidance for other centers, and what's the role of ALDonnect in all this? And do you think there's a way that ALDonnect can help facilitate, guidance? It's already happened for the adrenal insufficiency and endocrine part, but is there sort of, I know that New York State has also done this, and Eric could also speak to that briefly, but maybe just to comment on that.
Yeah, so I think publishing scientific papers is lovely, but it's kind of talking to the people that already know what to do and are already engaged and interested. So I think the most important thing is for us as a clinical team to come together with our recommendations, but then disseminate it. And that's where I see ALDonnect as playing a huge role in getting the guidelines out to every single center. And typically states have designated referral centers, and making sure that every single one of those referral centers is aware of the national guidelines, I think is a very ALDonnect role.
Sorry, another quick question. So do you get a sense of feedback from parents about the newborn screening process? And is that another way that we could enhance sort of our care?
Yeah, I would say one of the weaknesses of Pennsylvania is that families are referred to us before they have a genetic confirmation. And so that is a huge barrier to kind of the acceptance in their journey. And so I would love for states, if we're doing new states that are moving this along, to really not reveal it to the family that there's a problem until we're certain that there's a problem. I don't love that there's a week where I meet a family, I'm trying to not scare them so much that they don't come back, but I also don't have the full information to be able to guide them at that moment. So there's a week where I'm really not happy with how things are going. And then I actually bring them back for TLC visits regularly, and that's one of the reasons I see my families so frequently. And I basically make my schedule open to them. I say, what day works for you? What time works for you? And then we just make sure that they feel connected to the community. They're a very different family group than the typical family or the historical family that's been affected by ALD. And I have heard from some families that they feel less connected to the larger ALD community because their journey is so unique. So I think outreach groups to really target the families and help them through their very unique journey would be important as well.
Well, thank you so much. I just had a question about how patients actually get to you after the newborn screening and that there's been a presumed positive. And are you seeing that nationwide, or is there a disconnect between screening and then ultimate care?
Oh, that's a big question, and it really varies state by state. I'm sure that there are some heads of newborn screen programs here from a more general. Anyone? So I can talk to you about the Pennsylvania neurology experience. So the families are called and told that there is an abnormal change on the newborn screen that needs confirmation. That's scary though. They don't really know what it is. Sometimes they're told what the change is in, and then they start Googling before they can talk to a provider that can kind of counsel them through it. So it's not ideal, but that is historically how it's done. Usually it's referred to 2 or 3 major centers that receive all of the newborn screen children. So they have a set protocol.
Florian, this is maybe a question for you and for other centers who sort of think about high volume numbers of ALD patients, but is there underway a centralized effort to collect sort of post-screening data that we can contribute to?
Yeah, that's probably a good segue for actually Anna as well, with the Hunter's Hope experience in Grab. But my impression, and Anne Moser will also know more details, is every state does it on their own, and even within each state, the metabolic centers often are struggling with maintaining, follow-up. And one thing that the newborn screening centers in every state are complaining about is their lack of ability to have follow-up data and understand disease states. And there is something called the CLSI, which I don't think I see. Stefan Kemp and I are on it. Anne is also on these calls. They are really trying to determine, based on the very long chain fatty acid levels obtained at newborn screening, what the proper cutoffs are based on disease manifestations. And it's a very challenging field.
And I agree with you that I think, ALD is really completely a novel paradigm, because most newborn screening programs are for sort of much more immediate short-term disease manifestations. And so I think that's part of the reason why the model that's currently used, which is where each state does its local follow-up, might not be sufficient in this case, because it'll take us longer to get accurate data to sort of basically understand what happens when you screen. So I just wonder, most of the newborn screening labs are restricted from sharing data just by HIPAA and other things, but if there were IRB-approved protocols that were at each state has a fairly restricted number of centers that receives that data and then does that follow-up, it wouldn't be inconceivable or impossible to engage with those centers, not that are doing the screening, but the centers that are doing the post-screening follow-up. And I just think it would be something that would be lovely to see, and that we certainly would be happy to contribute to if that were created.
And we've had these discussions with various groups also in San Diego with the California newborn screening group. In the end, I think what we found is that probably our patient portal is the most valuable asset in this whole process, because it really overcomes a lot of those individual IRB issues and local differences, and really empowers the patient to participate and consent online to this sharing of data. But how to roll that out and how to incentivize so that this can happen on a large scale is, I think, the challenge. I don't know. Alex?
Still requires at least one IRB.
Yeah, there's always an IRB.
Better than 50, or I don't know.